Right. So it's really nice to see you all. I recognize some familiar names as some new ones. So welcome to the first community medicine OSCE class in preparation for the ERPM part 2. So for those who don't know me, my name is Dr. Gamlath. I am a community medicine registrar and I'm doing my MD in community medicine. And today we are going to this class is to focus on giving you a sort of overview of what to expect in the ERPM Part 2 OSCE, especially related to the community medicine related stations and how you can sort of face them. So this is something that's new for all of us. So we also haven't seen this in, being used for the ERPM exams, and this is something new for you guys as well. So for today's session, right. So something I have to say upfront, I wanted to do about 8 to 10 stations today just to give you an idea, and then another 8 to 10 stations on the next day. But due to unavoidable reasons, I might have to cut today's session a little bit short. So we'll see how many stations I can go. If I cannot cover anything, I will complete everything on the next day, which should be on the 22nd, right? So moving onwards, the only instructions we have right now for the ERPM exam are this guideline, which has been released earlier. So in this circular, if you go down, there is a part which describes your ERPM part 2. So in the part 2, it's supposed to be an OSCE or objective structured examination. And this is basically where you will be expected to do practical stuff, and we will see what is expected from you in a little while. So there are going to be stations, and each of these stations, there's going to be you're going to be there for 10 minutes each, and there are going to be 20 stations out of those 18 stations as mentioned here. So you can see in the circular, it's mentioned 18 will be test stations, 2 will be rest stations. So overall, you're going to have to stay there for 3 hours and 20 minutes, out of which 3 hours are going to be, you are going to be continuously going to have to face questions, and also 3 hours at a stretch is not easy. So this is going to be physically challenging as well. So with regard to the stations, they have described the distribution of questions from each subject as well. So you're going to have 4 questions from medicine, 3 from pediatrics, 3 from surgery, and so on. And for community medicine, you're going to have 2 questions. However, they say that the questions would be of mixed content. So that means that you will have sometimes the stations will be mixed up. So that might mean you might get a station on maternal health, antenatal care, and you might mix in obstetric, gyn and obs, as well as community medicine. And then you might get some sort of case of alcohol abuse or something like that, where they might mix medicine and psychiatry. So you can expect stuff like that as well. So we are hoping that they will sort of release new additional sort of guideline or circular or something like that, which will go into more detail, which will give more details about these stations. But for now, this is the only these are the only details we have. And each station is expected to carry equal marks, and overall this entire part will have 50%, right, out of your total marks. So part 1, your MCQs, and this will add up to 100. This will be 50%. So for each station, you will be getting around 2.7 marks, something like that, and this will be added up. So you might be able to compensate. Like if you were not able to do good in one station, you might be able to pick it up with the other station. So what to expect? So since there's no additional information regarding this exam, what we are going to have to base our stations, or what I based my stations on, was the PLAB exam. So there, in that exam, what you usually had was these sort of 6 stations, right? So since these are 10-minute stations, you are not expected to do everything there. So they will be very focused. So these stations will be sort of evaluating a single or multiple components out of this. So you might have stations which are evaluating your history taking, where you have to take a focused history from a simulated patient, or maybe from an actual patient, right? And they will observe you taking the history. And then there might be a physical examination station, where you have to do an examination on a patient, and they will be watching you and evaluating you. And then there might be interpretation stuff. They might give you a lab report, or from our end, from community medicine, they might give you a growth chart or something like that, or notification form or stuff like that, which is related to community medicine, and ask you to interpret that, a report or a chart or something like that. Or they might test your procedure skills, like they might tell you to do a procedure, might tell you to do a speculum examination or stuff like that, right? Or you might be expected to do counseling or education. So this is very heavy, these sort of stations are very heavy overseas, where they sort of really look into how you interact with patients, how you talk to patients and stuff like that. So then these stations might be there as well, or they might be there in one of the stations as a component. So you need to be prepared for those as well. And then you have your straightforward viva, type of stations, where they will ask you structured questions regarding a case scenario, stuff like that. So again, we don't know how it will be structured, but probably you will sort of get an instruction sheet of what to expect within the station beforehand, and you might be given as maybe maybe 1 minute or time like that to read it and then go into the station, so you can just carry it out. But again, we don't know that for sure right now, so we'll have to wait for additional guidance on that. So what we do know is that anyway, there will be 18 stations where you will have to sort of go in and do some of these or combination of these things, right? So, and there will be overall 20 stations going on for 10, which is 3 hours and 20 minutes. So that's a long duration, so you need to be ready for that, and you need to sort of be very precise in your answering, right? So you need to know your procedures very well, right? The emergency management of stuff, all of those things need to be at your fingertips. They should come out at the spinal level, so you need to know that. And before answering, always just take a minute. Like, it's always good that you will be able, if you were able to give a structured answer. So don't get hurried, so don't be in a hurry to just get everything out. Just take a moment. When something is asked from you, just take a moment, structure your answer, and then start answering, right? So prioritize the important stuff in your response early, and make sure to speak clearly and be professional, right? This is just like a case, like long cases and short cases, so you need to dress appropriately and stuff like that, and be professional. And during our station, we look into the sort of stations that you might get with regard to community medicine, and in those we will see what you can sort of expect. So I will try to go over some stations. So these stations will be, some will be mostly community medicine based stuff, some will be combined ones with some sort of either genenobs or pediatrics, and then you have a sort of community medicine part. And then some I will a little bit focus on the clinical part as well, because in some circumstances, like in community medicine, we focus on the clinical stuff as well. For example, as MOH, you will be expected to do certain clinical things as well. So we will be looking at management of certain diseases and certain conditions from a primary health perspective, right? So of course, since these are OSCE stations, I'm going to need your input as well. So I need somebody to answer as well. Otherwise, it's going to be very difficult to sort of have a discussion regarding this. So we'll go ahead with the questions, and these are stations I sort of developed after I looked at what was done in the other exams out, especially in the PLAB exams, how they structured their questions and stuff. So we'll go on with the first station. So in this station, imagine this is the scenario. You have a 34-year-old male patient who's admitted to the medical ward with a 3-month history of a productive cough and unintentional weight loss and drenching night sweats and low-grade fevers. So a chest x-ray showed features of upper right lobe cavitation. So then what do you do next? You do a sputum analysis, 3-day sputum analysis, which arrived at the diagnosis of smear positive pulmonary tuberculosis. So this is a sort of clinical questions. You might get an actual patient with this scenario as well, where you might be able have to take a history and then they will question you. Here I have just given you the scenario because I wanted to focus on the community medicine aspects. So the first question I would ask you is, and can I have a volunteer as well, so that this is a little bit interactive. I want you to answer as well, and I will give you your feedbacks, and you can have and just make this sort of a mock exam, so you can figure out how much you know and how well you can answer these sort of questions. Right. So the first question is TB a notifiable disease in Sri Lanka? If so, how is it notified? So this is a very simple thing. I wanted to start off very simply. Right. So do I have any volunteers?
Yes.
Sanka, good. So what do you think? Is TB a notifiable disease in Sri Lanka?
It is, sir.
Yeah. So how is it notified?
So we have to fill the H816 form, I think.
Hmm.
And
Yeah.
then we have to get the MOH and the PHIs involved in that area.
Hmm.
And
Right. So good. So you have a basic understanding of the how TB is notified. So you need to be a little bit more detailed, and we will look into that later onwards, right? So good. You have a basic overall understanding. TB is a notifiable disease, and there are, for now, I will just say there are two ways you can notify TB, right? In this case, what is this? This is diagnosed case of TB, right? In diagnosed case of TB, we have a special notification form called the H860. This is what is used to notify TB, and we will see how that pathway is, how that is notified in a little while, right? So moving on to the next question. So what is the treatment procedure for a newly diagnosed pulmonary TB patient? Just to the best of your knowledge.
so we can go for the DOTS procedure.
Yes. So what does that entail in a newly diagnosed pulmonary TB patient? How do you give dots? Or rather, what is the pharmacological treatment?
4-HRZ-E.
Yeah.
2 months of
Yeah. So good. You know about the HRZD. So there are two phases, right? There's something called the intensive phase and there's something called the continuation phase, right? So the pulmonary TB treatment is divided into two phases. Overall, there are 6 months of treatment, and the first 2 months is called the intensive phase. The next 4 months is called the continuous phase, right? And there are the drug regimes are different. For the intensive phase, you have one drug, which is called HRZD, and then for the continuation phase, you have another drug, which is not one drug, it's actually a combination drug. You have two drugs in that sort of one tablet, and we will look at that as well. So you need to have a clear understanding of that as well. This might come in the attached to the medicine OSCE, or it might come as community medicine, because from both fields this is important, right? And we look into the details in a little while, right? Next, so the patient is discharged after 1 week. Okay, you have treated in hospital for 1 week, and then how is the treatment continued? What do you think? So I told that you need to continue this for 6 months, right? So
yes.
then after hospital discharge, what happens?
So when the he has to be present with someone when he takes the drug. So he has to
Yeah,
follow
that's
that.
exactly. So that's part of the DOTS treatment, right? And we will look at what DOTS treatment is. One basic thing up to now. So after you are discharged from a hospital, there has to be a certain institute which takes up the responsibility, or a certain person who takes up the responsibility of giving that treatment to this patient. So basically, you should, after the hospital discharge, you are referred to a special place called the district chest clinic, right? First of all, and then the district chest clinic will arrange the outpatient treatment, and we will look at that also in a little while. And basically the patient can go home, that's okay, and the district chest clinic will arrange who will give the dots, or the dots provider, and we look into that details in a little while. Next, so what is the importance of dots? So we talked about how DOTS was direct observed therapy, where the patient has to take the treatment in front of some person, right? That's what the meaning of DOTS. So why is it important?
So we can make sure that the drug is taken by the patient. So for him as well as
Exactly.
the society, it will be better.
Yes. One is compliance. Why is you can ensure that the patient is compliant for the duration of the treatment, from the intensive phase to the continuation phase. What is an important aspect of that? Why isn't it good for people to sort of stop treatment halfway?
So resistance can happen.
Exactly, resistance. So antibiotic resistance is more prone to occur if they are partially treated. So those are the two reasons. Good. So next, final question. What are the steps which should be taken for household contacts of this patient?
So the contact should be tested for TB.
Exactly.
And maybe isolation. If TB is positive, we should isolate the patients.
We don't do isolation with TB. It's not recommended anymore. But there are certain things. How do you test for TB? Do you have any idea?
It's a Mantoux test.
Yeah, we can do Mantoux. And how do you do Mantoux if they are producing sputum? If they are not producing sputum, we have to do a chest X-ray, right? We'll look into those details. Good. So you were able to answer most of the questions. And in this sort of a scenario, in sort of an OSCE type of situation, the examiners will have some sort of a answer sheet, right? They will have some sort of a marking criteria which will outline the main sort of points they have to look out for and give marks. So we don't know how many marks they have allocated per station, right? It might be 10, it might be 20, it might be 50, right? But just to give you a sort of idea, I sort of made a rough sketch of what I would expect in an community medicine station, assuming I will give about 50 marks per station, right? So for each of the questions, there was important things I wanted to highlight out of you, but there was some freedom. You come out with important things as well, but there were certain things I expected. So we'll go over the TB management very quickly because this can come up on the medicine side as well as the community medicine side, right? So TB is a very important disease in Sri Lanka, and we have many preventive care services which we have targeted for prevention of TB. One is the BCG vaccination. It's not a main thing. BCG only prevents what? Disseminated TB in very young children. The effect is only up to something like 10 years, right? Afterwards, it doesn't prevent, right? But it does prevent against some form of TB. That's why I put it here. Then early diagnosis and treatment. By making sure we diagnose these cases early and treating them correctly, we can make sure that they don't spread. And then we have a notification procedures and contact tracing and screening of all contacts of TB patients. And then we also have these additional things we will look into, right? So the notification thing, there are two ways you can notify diseases. Number one, on suspicion, you can notify diseases using the H544 form. So you need to know some H forms, right? So this is one of the forms that you need to know the number for, right? This is the H544 form, which is used to notify communicable diseases in general. So in the back of this form, you will have a bunch of diseases, and I will discuss this later onwards. And those diseases on suspicion, you have to notify using this form, right? But in our case, what was it? It was a diagnosed case of TB. So that patient has already been diagnosed. So then you have a special notification form, which is the H816 or the H816A more specifically, right? That is the form that is used to notify a TB case which is diagnosed, right? And there is a way you should send this. Just know from the hospitals, these are sent like this, right? One is kept at the institute and one is sent to the director NPTCC. It's the central level institute in charge of TB and respiratory diseases, right? And on discharge of patients, they are referred to the district chest clinic, right? There are institutes in every district called district chest clinics or DCCs. These are district chest clinics, right? So when a patient is diagnosed in the hospital and they are treated for some time, on discharge, like I mentioned, their treatment goes on for 6 months. So then some institute needs to take up the responsibility of making sure that patient gets the treatment. So then because of that, these patients on discharge are referred to the district chest clinics of their relevant districts, and the district chest clinic will decide what to do with this patient, right? They can, for the intensive phase, and we will look at the treatments in a little while, and they will look at what to do. So going on with the notification stuff. So once you have filled the H816, on confirmation of the diagnosis, you should send it to the MOH, right? So the relevant MOH of the the area where the person resides, right? So once the MOH gets it, he will send it to the relevant area PHI. And then the area PHI, there are some registers on the way you have to fill, right? These are nice to know things, but you need to know the main things. The main thing is it is sent to the area PHI. And the area PHI has to do two things. Number one, he has to look at the patient, right? He has to investigate the case. Second, he has to do contact tracing and screening. So one, he has to identify the household contacts or the contacts of that patient, TB patient, and then those contacts should be screened for TB. That is the other part. And the screening is done by the district chest clinic. And then he has to investigate the case. So there are certain things the PHI should do regarding the index case of this TB patient, right? So first of all, he has to confirm that this is TB and this is pulmonary TB. All those things has to be confirmed by looking at the diagnosis card. And then he has to make sure what of the compliance. So he has to look into now who is giving the DOTS treatment for this patient, in which phase is he taking the correct treatment. All of that he has to look at, right? And then he has to fill a form called the H816B, and this he will send to the district chest clinic. So another thing to note here, the district chest clinic, the head of the institute of the district chest clinic is called the district tuberculosis control officer, or the DTCO. That's the head of the institute of the district chest clinic, and that is why it's mentioned DTCO, but basically it's the district chest clinic, right? So that's the person who is in charge of the district chest clinic. In addition to that, there are certain other reports that he has to fill, including this H411, and then there is a whole notification procedure. After that, we will discuss this later onwards when we discuss, the overall notification procedure, right? This is how the disease is notified. So you need to know a little bit about these details as well. So then regarding the treatment, so the treatment procedure is something called the DOTS strategy or the DOTS treatment, and this stands for directly observed treatment, right? So what is that? So basically, in this sort of strategy, what is expected is that the patient to take the treatment and basically swallow the pills in front of somebody, some sort of a person. And this person can be a healthcare worker, it can even be a non-healthcare worker, and who should be trained in how to administer doses and how to supervise that. But the choosing of a DOTS provider can be done in discussion with the patient. So whoever is easily accessible to that patient, you can choose as the DOTS provider. So that can be a field health officer such as the MOH, AMOH, or the public health nursing sisters, or the PHIs or PHMs at the MOH office, or the patient can come to the district chest clinic and get the DOTS treatment from there as well. So in the DOTS treatment, like I mentioned, you have two phases. For pulmonary, so the treatment depends on the type of TB as well, whether it's a new case, whether it's a partially treated case, whether it's a disseminated TB, extrapulmonary TB, all of that the treatment will differ, right? From a community medicine perspective, you should know the basic one, which is the treatment of a new case of pulmonary TB, right? And there you have the treatment phase is divided into two. You have an intensive phase and a continuation phase. So in the intensive phase, that lasts for 2 months, and you have 4 drugs being given, which is in one tablet. And then you have a continuation phase, which is for 4 months, where you have 2 drugs being given again in one single tablet, right? So in the intensive phase, what you give is this HRZD, which has isoniazid, rifampicin, pyrazinamide, and ethambutol, right? These are the 4 drugs, right? And in the continuation phase, what you give is the HR tablets, which has only isoniazid and rifampicin. So you need to know those details. So those are the pharmacological management. And again, how much of these drugs you give, how many tablets you give, depends on the body weight, right? That's an additional thing, right? So depending on the body weight, the number of tablets will change, right? So all of that you need to start as soon as you diagnose the patient. And once the patient is, in our case scenario, the patient was diagnosed in a ward, and then he was treated in ward and then discharged. So on discharge, ideally that patient should be referred to the district chest clinic, and they will take up how to manage this patient, right? Right. So you need to know all this stuff. So right. So I hope I gave you a basic understanding of how to manage TB and how sort of the station would go. So this sort of TB case can come up in your, medicine, general medicine, as well as community medicine. You might be expected to do take a history. So you need to know the clinical aspect of it, the medicine side aspect of it. So what do you do for that? And then you need to also know about the community medicine part, which is the notification. You need to know what the PHI does, and then you need to know about the contact screening. So the contact screening I forgot to tell. So the household contacts, they should be identified by the PHI, and then the PHI should refer to the district chest clinics for screening of those contacts. And the screening will be done for all the contacts via chest X-ray. And if the person can produce sputum, then you will do a sputum AFB as well, right? In addition to that, for the extremes of ages, for very young children and for the elderly, they are supposed to undergo prophylaxis as well. So that is also part of this the household contact screening as well. So you need to know that as well. So for the household contacts, if they are very young, less than 5 years, or if they are very old, more than 65 years, they have to undergo prophylaxis. And before you give prophylaxis, you need to exclude active disease. So you need to do a MAN2 test and exclude the active disease, and then you start isoniazid prophylaxis for those household contacts who are the extremes of ages. So you need to know those details as well, right. So we go on to the next station. So this is going to be a little bit more of a clinical station. So that was more of a mix. So for this station, this will be a mix of more focused on the clinical aspects. So here we are going to talk about anemia in pregnancy. So this is important in community medicine as well as the MOH. You will be doing antenatal clinics, and you will have these cases coming up, right? So you are a medical officer at a primary care antenatal clinic. A 28-year-old woman at 13 weeks of POA comes in for a routine POA visit, right? Her full blood count report shows the following parameters: hemoglobin was 9, MCV was 72, MCHC 30, and platelets were normal. And what are you required to do? You are required to take a brief history to confirm the presence of or the absence of any symptoms, and to assess any contributing factors. And then, so I have mixed up some different things here as well. So there's a history taking part, and then there's a sort of counseling or education part. Now you have to, next part is you have to educate that patient on what this blood report means, and then you have to counsel her on the next steps of management, and you do not need to do a physical examination, right? So this is a little bit long, because I don't think you will be able to do all of this stuff in 10 minutes. But what I wanted to do is to give you an idea about anemia in pregnancy overall, right? So just imagine I'm the mother and you can take a history. So do I have any volunteers for this as well? You can ask any question and I will be the patient. So can I have somebody as the volunteer? Aim, how about you? You don't need to turn on the camera, just the mic is alone is enough, and you can just ask, what would you ask in a mother who is coming with anemia? Girindu? Induja? It's okay if you don't know, right? It's just fine. You are learning right now, so it's okay. Just just for me to give you feedback. Oh, yes, Mami, just go on.
How long the anemia lasts?
Yes, you can ask that, but this is the first. Just imagine she hasn't had the hemoglobin. She hasn't checked her full blood count earlier. So then this is the first time the hemoglobin has been low. What's the first thing you would ask? Whether she has symptoms of anemia, right? So what are the symptoms of anemia?
The
What are the
fatigue.
symptoms? Yeah, fatigue, yes. Others?
Pale.
That's a sign. Paleness is a sign. What is another common symptom? It's, what about shortness of breath?
Yeah.
Yes. Lethargy?
Yes.
Yes, could be. So shortness of breath, lethargy, and yes, fatigue. Lesi mahansi wenada, husma ganna amaru wenada. Saha, how long has it been there? So you can confirm the duration of symptoms. So, okay, she doesn't have any symptoms. Next, what should, okay, you have excluded all other symptoms as well. Next, what would you ask about? Right. A good point to sort of do in your sort of cases is to take a focused history. So in a focused history, what you should do is first what? The first component. So obviously you need to take the bio details, right? The name, the age, the address, and all of those stuff you take upfront. That's fine. Next, you will have two types of cases coming. When you had cases, you had two types of cases coming. And even in OSCE stations, when you're supposed to take a history taking cases will come in two varieties, right? Number one will be you will have to make a diagnosis. These are diagnostic cases. Patients will be coming with certain symptoms. What you are expected to do is take a history focused on diagnosing that patient. So those will be diagnostic history cases. The other ones will be already diagnosed cases, and these will be your main task will be to assess the management, right? They will be coming with a diagnosis card or clinic book, and they will have the diagnosis written all over. The patient will know the diagnosis, and they will be instructed to tell you the diagnosis. So in those sort of cases, those are management cases. There you will have to focus on the management of that patient. The diagnosis is not a mystery. So then you will have to assess, is the management correct? How is the compliance? What is the further management of this patient? What do you expect to do further? So these sort of things are separate. How you approach them are different. For diagnostic case, so this is what? So this is already a little bit a mix of those two. So in a case like this, you already know this is an anemia case. That's fine. So next, what you need to do is you need to take a history focused on what? The management. So to manage, what do you need to know? You need to know the cause of the anemia. Anemia is not the same, right? Anemia might be due to iron deficiency anemia. It might be due to folic acid deficiency. It might be due to bleeding. There might be lots of causes, right? So then to manage that, you need to know the cause of the anemia, right? So in these sort of cases, the first part of your history should be focused on evaluating the symptoms. So then you have to ask whether there are certain symptoms of anemia. If it is symptomatic anemia, that is, the management of that is completely different. If it is asymptomatic anemia, management is completely different. So you need to ask about the symptoms, you need to ask about duration, and then you need to ask about what? The effect of on their daily activities. Is this interfering with their daily activities? Can you carry out your routine daily household activities, or can't you do those because of this lethargy or shortness of breath or stuff like that, right? Then after you have evaluated the symptoms, next you have to look at the causes. So the next part is looking at the causes of your history, the causes of the anemia. So then what are the causes of anemia? Like I said, it could be iron deficiency. So how do you assess that? So you have to ask about what? You have to ask about the dietary intake. So you have to ask, so after pregnancy, so this 13 weeks of POA, she might have started, vomiting and stuff like that. So her intake might be low. So then you need to ask about intake, and then you need to ask about what? What do you call, protein rich foods. Is she taking meat? Is she taking fish? Is she taking eggs? Has she developed some sort of an aversion to those foods? Is she not taking them anymore? So you need to ask about that. Then you need to ask about what? Right? You need to ask about any bleeding. So if she had heavy menstrual bleeding prior to becoming pregnant, heavy menstrual periods, intermenstrual bleeding, any sort of bleeding tendencies before, then obviously that anemia might have carried carried on to the pregnancy period as well. So you will have anemia during this pregnancy as well. So then that is due to bleeding. So like that, you need to evaluate the causes of anemia as well in next part. Next, you have to evaluate the possible complications, right? Of course, in this case, there will not be any complications. So generally, in a management case, you need to evaluate the complications as well. So if this was, a medicine case, if this was something like CKD, then you have to evaluate possible CKD complications as well. In anemia, of course, there's not many complications you need to worry about, so you don't need to focus on that a lot in here. But basically, this is important, right? If an anemia patient comes, you need to evaluate the causes. So you need to ask about the dietary history, you need to ask about bleeding to figure out causes. And next, because this is a patient who is pregnant, there are certain things that we give for her, right? If you can remember the management of an antenatal mother, we start supplementation. So supplementation of a pregnant mother is something that's routinely been done. And what do you supplement? You give them iron, you give them vitamin C, you give them calcium, and you give them folic. So after 12 weeks, you don't give folic acid. You are supposed to take them preconceptually before 3 months of pregnancy, and then continue up to 12 weeks of POA. Then afterwards, it's not recommended. What is recommended is iron. So iron is supposed to be started after 12 weeks of POA, or even before that, if the vomiting and hyperemesis, so the vomiting subsides, not hyperemesis. So that's supposed to be started. So if that is started, you have to ask about that as well. Is she tolerating that? Is she taking that? Is she taking that correctly? So you need to ask about that, because this is 13 weeks. Now she is supposed to have started on iron. So you need to ask about her compliance to the treatment as well, right? So how are you supposed to take iron? So we'll discuss that later on once, right? So then we'll I sort of went off topic a little bit. I want to discuss all of these questions, then go into the theory part. So we'll go on with the rest of the questions as well. Then we'll go on to the important theory stuff. Next, how would you explain the blood report findings to the patient in simple terms? So this is something where the counseling part comes in. So you need to be able to explain this blood report to the patient in simple terms, right? So in this case, it's very practically also it's very important. So you will be expected to tell about the blood report. Sometimes you will be expected to counsel on the treatment, and sometimes you will be expected to counsel on the possible side effects and how when to come back and the follow-up management and stuff like that. Here, it's what I'm expecting is just the blood report. So here, what you have to tell the patient is that what are the important things that you need to mention. Number one, her hemoglobin is low, right? And you need to before this, you need to ensure that you have a clear understanding of the patient, right? The education level and stuff like that you need to take into account, right? Then in simple language, tell according to this full blood count report, you have anemia. This is and depending on the education level, you can go even more details, right? This is due to most probably on your history, this might be due to a lack of iron. So because of that, you need to take iron supplements, and then you can have this whole other conversation on how to take iron. So you need to be able to counsel that patient on how to take iron. So how do you take iron tablets? So you are supposed to take them either 1 hour before main meal or 2 hours after. So you cannot mix them in with meals because their absorption might be affected, right? And also you cannot take any tea, coffee or stuff like that with them, and you should not take those tablets with calcium. So stuff like that you need to tell in a simple manner. And then you might be asked to do nutritional counseling as well. So that's the next part, right? So counsel on the next steps of management, right? Iron supplementation, diet, and follow-up. So and so these sort of stuff, in addition to the theory components, you will be evaluated on how well you will be able to tell this stuff to the simulated patient or actual patient, right? They will be looking and they will be viewing you, they will be looking at you to see how well you explain. So you need to use simple language. Don't use overcomplicated stuff. Use simple language and just tell what is expected of them, right? So we will look at the management and then, right, so this is the sort of basic marking scheme I generated for this station. So you can see, if in the history you ask about current symptoms, you get 2 marks. You have to confirm the antenatal care history, whether she has started supplementation, is she a multi-para mother, does she have other risk factors for anemia, stuff like that. And then you have to have a dietary component as well. You have to take a basic dietary history, not a 24-hour dietary recall. You can't do that. Just ask whether she takes iron rich foods, that's all. And then about tea consumption as well, so because that will interfere with the iron absorption. Just ask whether she consumes tea, coffee close to the main meals as well. And then you can ask about bleeding history, past anemia, and then about supplement use, right? Then that's an important thing. You have to ask, is she taking iron supplements? How long has he been taking them? How is her compliance? Is she having side effects and stuff like that? So that might affect. And then you need to explain the treatment. You need to explain the blood report to her in simple details. And then the counseling part, again, there are few important things that I would focus on. So you need to focus on how you give iron and folic acid supplementation, and how you give advice on iron rich diet. So you have to tell them to take iron rich foods, right? Mas, malu, bittara, kadala, kaupi, mung ඇට, right? For all three meals in some portions. I tell them to take what they can tolerate. So in some pregnant mothers, they might not be able to tolerate certain foods. So then you have to advise, right? Mas kanna බැන්න, මාළු හරි කන්න, ලොකු මාළු කන්න බැන්න, පොඩි මාළු හරි කන්න, හාල් මැස්සෝ හරි කන්න. If you can't eat that, eat eggs, stuff like that. You have to give them options and ask about it. Can you tolerate this? Have you eaten this? And stuff like that. Just have a conversation with them, right? And you can do this very, very quickly as well, right? And then you have to warn about potential side effects. So iron treatment has side effects. It has GI side effects, nausea, sort of epigastric sort of burning sensation, GORD, stuff like that. So you need to make them aware. The good thing is you can change our formulations, and that will, basically these side effects, most of the time women have for certain formulations of the drug. So all you have to do is change the formulation. So you need to tell them, if you have side effects, don't just stop taking them. Just come back and we will write you a prescription for a different formulation, and we will see if the side effects go away. So you need to advise on that as well. Next, the important thing, timing, right? You need to tell them, this is a drug, the absorption of which, the effect of which depends on the timing of your intake of the drug. So you need to take them either කන්න පෑයකට කලින්, කෑවට පෑ දෙකට පස්සේ, ඒව ගන්නකොට don't take any tea, coffee, stuff like that. They will impair the absorption. And also you have to take them with the vitamin C. If you are taking them separately, you have to take them with vitamin C, and that improves the absorption of the iron. And then if you are taking calcium, what do you have to advise? You have to take that separately, right? And then you have to check that the patient understands as well. So this is the important component I want to emphasize here. So in these counseling things, at the end, you need to ensure that the patient understands. Just ask just one or two statements. මං කියපු දේ තේරුණාද? මොනවා හරි තේරුම් නැති දෙයක් තියෙනවා නම් ආට අහන්න පුළුවන්. You need to end with that, right? You need to make sure that she understands, and you should give her time to ask questions back regarding any unclear areas, right? This is not just for community medicine, but for all the OSCE stations, right, where you have to do some sort of a counseling thing, right? You have to ask them about their understanding, whether they understood, and if they have any questions for you. If you can ask in the middle of the your counseling as well, that would be better, right? But if you are sort of if you don't have much time, because there's going to be a bell ringing and you have to move at the end, so if you are not sure about time, you can do one at the end. If you have time, just in the middle also, just ask මෙච්චර වෙලා කියපු දේ තේරුණාද, මොන හරි ප්‍රශ්න තියෙනවද, something like that. Just put it in, right? And always make have a professional tone, clear, empathic communication, professionalism, respectful, stuff like that, basic, right? Sorry. Right. Any questions up to now regarding these counseling stations and stuff like that? Okay. So regarding your antenatal comorbidities, you need to have a sort of basic understanding regarding these three, at least from a community medicine perspective, right? So these are the three main conditions we look out for in the MOH antenatal clinic setting. So in this, anemia is one of the commonest conditions that you will come across, and here you have a definition of anemia, so you need to stick to that. And then, like I mentioned, causes of anemia, it might be completely, it can change from there's a lot of causes of anemia, and one thing I forgot actually was this hemoglobinopathies, right? So you need to be aware of thalassemia as well. So this is where the family history comes into play. So you need to ask about family history as well of anemia. So if you are going to be asking about history of anemia, right? Next, in anemia of pregnancy, most of the time it's associated with iron deficiency anemia, and so there's some complications which arise from it as well. So the investigation, so because anemia is so common in pregnancy, what we are trying to do is we are trying to detect it early. So we do 2 full blood counts, one at the booking visit and the next one at 28 weeks. So in either of these you can detect anemia, right? In addition to that, that's the routine procedure for all pregnant mothers. In addition to that, for high risk women, we also do an additional full blood count in the middle as well, around 20 to 24 weeks, right? And for interventions, if you for all pregnant women, sort of as a universal precaution, we give iron for everybody, and the dose is 30 milligrams elemental iron now, right? This has been changed recently, so we only give 30 milligrams elemental iron now, along with vitamin C. For anemic mothers, the management depends on the level of anemia, the cause of anemia, the presence of anemic symptoms, the POA, and the toleration of the formulations, right? So that is why you have to ask about anemic symptoms, right? If the patient is anemic, our management is completely different. And the POA, if the patient is getting closer and closer to the delivery date, we are more concerned about anemia, right, than we are if that patient was, like 12 or 13 weeks of POA, right? So for the management, we can do dietary modification, we can give oral iron, parenteral iron, and blood transfusions, right? So here the dietary modification part is the most important with regard to community medicine. So all women need to be counseled on this. So you need to encourage consumption of iron rich foods, meat, fish, mas, malu, bitter, those sort of stuff. And so you need to tell them to take it on an empty stomach, that's 1 hour before a meal or 2 hours after a meal. And you need to take it with vitamin C, and you need to avoid tea and coffee because this will interfere with the absorption, right? Next, oral iron, the therapeutic dose is 120 milligrams. This is, so sometimes the earlier double dose iron, right? Because the earlier we used to use 60 milligram elemental iron, and so the therapeutic dose was 120. So if you have a patient who's diagnosed with anemia, you don't give 30, you give 120 milligrams of elemental iron, right? And then you give it for 3 months, regardless of the how much the hemoglobin level is. You need to continue for 3 months, and you need to review with a full blood count. And ideally you should review at 1 month duration, right? At 1 month it might be improving, but still you continue to give iron for 3 months, because you need to replenish the stores of iron as well, right? Right. And right, if the patient is not responding to oral iron and the anemia is worsening, from a community medicine perspective, if you are managing this patient from the MOH clinic or at an OPD level, then you need to refer them to a specialist clinic for further management. If it's a low PO, if the PO is sort of a little bit low, you go ahead with parenteral iron. So that is much more better, because that will replenish the iron stores as well. If you are much more closer to the delivery, like more than 36 weeks of POA, then the specialist has to take a decision on blood transfusion as well, because you need to increase the full blood, you need to increase the hemoglobin very fast in anticipation of a delivery. Because how long does parenteral iron, how long does it take to replenish your stores? It takes a long time. So read that up, right? So folic acid deficiency, you manage it with folic acid 5 milligrams. And if it's vitamin B12, you have to give vitamin B12. and then worm treatment. So this is something that might trip you up. So we don't give routine worm treatment for pregnant mothers anymore. If there is a suspicion of worm infestation, that's only when you give worm treatment. Just because the patient has anemia, you don't give worm treatment anymore. You have to, confirm that the patient is has an infestation, and then only do we give worm treatment, right? And then in the postpartum period as well, if the mother had anemia close to her pregnancy, you need to make sure that she gets a full blood count after the delivery as well, prior to discharge. And in the postpartum period, you need to continue hematinics for 3 months postpartum period, right? For all mothers, right? For all mothers, right? And for all mothers, it's the 30 milligram, therapeutic, the prophylactic dose. If that was an anemic patient during her delivery and stuff like that, you can continue the therapeutic dose, right? So that is all regarding anemia and pregnancy, but you need to know details regarding what? Hyperglycemia in pregnancy and hypertension in pregnancy as well, right? So any questions up to now regarding antenatal management? What is expected of you? How to face, what are the other things that you need to know? Anything like that? Right. So we'll move on to the next station. So the next one is actually going to be a little bit community medicine heavy. So the previous one, it was a little bit clinical, it was a heavily clinical sort of station. This one is going to be more of a community medicine one. So this is an epidemiology based station. So in District X, there's a unusually high number of young adult males who have been diagnosed with chronic kidney disease. And many of them are agriculture workers or farmers who rely on well water for drinking. So it is suspected that some sort of a exposure to these environment factors is causing the CKD. And so you have the RDHS, or the Regional Director of Health Services. So he wants you to evaluate the possible risk factors for CKD. So given this sort of scenario, right, you have a chronic disease and you are suspecting some sort of environmental exposure, you don't know which. What sort of a study design would you use to evaluate this sort of a case? So you have different study designs. So you might have heard of, cohort studies, interventional studies, clinical trials, cross-sectional studies, stuff like that. So those are different study designs that you use when you want to research a certain specific topic. So out of those, what would you choose in this sort of scenario? Any idea? Anybody? Sharon, any idea what sort of study design would be best in this scenario?
Case control.
Exactly. Why? That's the next question.
It's we need to find the cause. It's retrospective.
Yes. So what's the main reason? Why is a cohort unsuitable for this? It takes a what?
It takes long time.
Exactly. This takes a long time. A cohort study takes a long time. A case control study can be done in a very short duration of time, and it's less expensive and much more easier to carry out. And the other main reason, this is one reason, as the initial study, this is very well suited, right? Because you can't wait, if you do a cohort study, you will have to choose a group of people and you will have to follow them up for a long time. Why? Because this is CKD you are talking about. CKD takes a long time to develop. So you need to follow them up for a long time. That is not possible here. What is the second reason? Main reason here. Case control studies allow you, what is the starting point of case control studies? What do you start off with? What are the two groups you start off with? Do you recruit on the basis of outcome?
The deceased outcome.
Yes, disease, exactly, disease or outcome. So you call them cases and controls, right? So then you can look at multiple exposures for those cases and controls, right? You can look at multiple exposures. In cohorts, what do you start off with? The exposure. So then, yeah. So then what can you look at there? So you can look at multiple outcomes, right? In a cohort study, you start off with specific exposures, and then you can follow them up to look at multiple outcomes. In case control studies, you start off with the outcome or the disease, and then you can look at multiple exposures. So here we don't know the specific exposure which is causing the CKD, but we know the outcome, right? We know this is CKD. So you can take CKD patients and control patients, and then you can evaluate multiple exposures to that specific outcome. So those are the two. There are others as well. So these are the two main reasons as to why a case control study would be much more appropriate in this scenario compared to a cohort study or cross-sectional study. So good. So next, what are the two most common biases in a case control study? Any idea? So what is a bias? Do you know what the bias is? Right, it's okay if you don't know. So bias, so in research, you can have errors happening, right? Right? You can have errors happening. These errors can happen due to several reasons, right? One reason is something called a bias, right? The other reasons are due to chance, right? There's random chance always. The other reason is something called confounding factors, right? Sometimes confounding factors are categorized as biases. Don't worry, even if you put them separately, that's okay. So biases are something called systematic errors, right? Systematic errors that distort the association between an exposure and outcome, right? These are systematic errors, and these happen due to what? These happen due to the study not being structured correctly, right? So systematic errors are called biases, and biases can occur at any stage of the research, right? When you are choosing this topic, when you are developing your methodology, when you're doing the analysis, at any point you can have biases. But to simplify it, all you need to know are they can happen at two places, right? They can happen when you are selecting the study participants. Why? Because in a research, you don't do the entire population. You can't research the entire population. You have to take a sample. So then you have to select that sample. So during that selection or sampling stage, you might have biases. Those are called sampling biases. Next, you will have a measurement stage where you measure certain characteristics of that patient. So there you will have biases related to measurement of those characteristics as well, right? So one set of biases you can have is selection bias, right? When you are selecting study participants, you can have biases regarding the people you select for the study. So when you are selecting, you will have to decide this patient is having CKD, this patient is not. So if your criteria aren't objective, then you will miss certain people. Maybe you might miss people with CKD. You might include people who don't have CKD as having CKD if you don't use proper criteria. So that is one example of how you can have bias, selection bias. The other stage you can have bias is when you are measuring certain characteristics. So in here, in case control studies, because you are doing this after these exposures have happened, only after the outcome has happened, what are you doing? You are asking them about the exposures. Okay, did you drink water from this well? Did you use this pesticide? Did you, eat these foods? So you are asking them to recall certain events which happened a long time back. So there you might have certain errors when you are trying to get that information. We call that bias a recall bias, right? So if you know these two biases, that's more than enough. Selection biases and recall bias. If you know that much, that would be more than enough, right? Right. So recall bias is something that's very prevalent in case control studies. In cohort studies, what is the bias? Main bias there? It is loss to follow-up, right? Loss to follow-up bias. Why? You are following people up for a long time, especially prospective cohort studies. You are taking group and you're following them up. And sometimes people might be, they might move out of the area. You might not be able to contact them. So we call it loss to follow-up. So in cohort studies, the main bias you have to deal with is loss to follow-up. In case control studies, the main bias is recall bias. There are other biases as well, but I just want to give you one bias per each study design, right? Right. So next, what is the most appropriate measure of association in a case control study? Any idea, Sharon?
It's odd ratio.
Exactly, odds ratio. Why? Why is it odds ratio and not relative risk? That's the next question that you might get asked. Right. So just overall, there are things called measures of association, right? So in statistical testing, right, we want to know two things. Number one, we want to know whether the exposure is actually associated with the outcome. Number one. The next thing is we want to know how much that association, the magnitude of that association, right? So to establish an association, we use hypothesis testing or tests of significance, right? Both these terms are okay. Hypothesis testing or tests of significance, or significance testing, sorry. Either of those two are fine. To evaluate the strength of association or the magnitude of that association, we use something called measures of association. And you have different measures of association. You have relative risk, you have odds ratio, you have something called prevalence rate ratio, and attributable risk. Out of these, in case control studies, you use odds ratio. In cohort studies, you use relative risk. Why is that? Because relative risk, you compare the incidence of disease. What is the incidence? It is the number of new cases, right? So incidence you can only calculate in cohort studies. Why? Because new cases you can calculate only in cohort studies. Because you're following them up, you can see the new cases coming up, and then you can count those new cases. So then you can calculate the incidence. In case control studies, the outcome has already happened. You are looking backwards, retrospectively. You can't count new cases. So you can't calculate the incidence, you can't calculate the relative risk. So that's why we have something called odds ratio, right? That is the reason why we go for odds ratio in case control studies, right? Right, good. So then the interpretation. So this is something that you might get to interpret, right? Confidence intervals, right? You might get interpretation of confidence intervals with regard to these questions. So that is a completely community medicine stuff. So how would you interpret this result? So the case control study found an odds ratio of 3 with a 95% confidence interval of 1.6 to 2.5 for environmental exposure to heavy metals, right? So now they have specified, okay, for heavy metals, there is an odds ratio of 3 when you are comparing regarding the association with CKD. So how do you interpret this result? Sharon, any idea?
I think the people who drink well water are 3 times more likely to get CKD than those who don't.
That is a general way of saying. There's a much more accurate way of saying that as well. Okay, that's fine. That's for now. Let's. That's a sort of oversimplified way of saying that, but that's fine. So then, how would you interpret the confidence interval?
I don't know, sir.
That's okay. That's fine. That's fine. If you don't know, that's fine. Okay, fine. So odds ratio you interpret in a specific way, right? Relative risk, you find that's the way you interpret it. Relative risk, you are comparing what? The incidence of disease in the exposed compared to incidence of disease in the unexposed, right? That's the relative risk. In odds ratio, what are you comparing? The odds of exposure in the disease compared to odds of exposure among the non-diseased, right? So what you told is correct in a sort of general way, right? But the more accurate interpretation is if you tell with the odds and using this sort of formula, right? So the way you interpret an odds ratio of 3 is, that means that the odds of exposure to heavy metals among CKD patients is 3 times that of the odds of exposure to heavy metals among patients without CKD. So you are always comparing the two groups you started off with. So your case control studies, you started off with diseased and non-diseased, CKD and non-CKD, and you are looking at how many have got this exposure of heavy metals. So then your interpretation should be similar to that. So the odds ratio of 3 means, that means the odds of exposure to heavy metals in CKD patients is 3 times that of the odds of exposure to heavy metals among people without CKD or the control patients. That is the most accurate interpretation of the odds ratio, right? Right. And then how do you interpret the confidence interval? So the confidence interval tells you the with how much confidence, tells you the range in which you believe that the true population value lies. So here in research, you are always taking a sample, right? Because you are taking a sample, you need a way to estimate the population parameter using that sample, right? So one way you do this is with confidence intervals. You tell, okay, the population parameter lies within this range, and that is what this is, and this is that range. And how do you interpret it? How do you interpret this 95% confidence interval? We are 95% confidence that the true population odds ratio for the exposure between heavy metals and CKD is between 1.6 and 5.2. That is the interpretation, right? And there's another part of it, but for now, did you get that? We are telling how the range in which the true population odds ratio will probably lie with a 95% confidence, right? There's a way you shouldn't interpret this, right? As well, that is very important to note. Otherwise, you might go and tell this wrong thing as well. So this is the wrong way to say it. Do not tell that there is a 95% probability that the odds ratio is between 1.6 and 5.2. That is not how you say it, right? That is wrong. That is not the way you say it. What do you say? You are 95% confident. Use the term already given, right? Confidence in terms, you are 95% confident, right? Another way of saying this is, if you carry this research out multiple times, 95% of the times the odds ratio would lie between 1.6 and 5.2. That's also a correct interpretation. That's also fine. The wrong one is if you say there's a 95% probability. That's wrong, right? So that's one part. So depending on that, then there's another part to that as well. Sorry, what is that? Whether this is a significant finding or not, right? So this confidence interval, if it contains 1, which is called the null value, we take that as a non-significant finding, right? Why? So you can have people with the exposure being more than, you can have the numerator being more than the denominator as well as less than the denominator if it's less than 1, right? Imagine you have a range of like something like 0.6 to 4.2. So this range contains the null value of 1. So that finding is not significant if you have a null, if the range contains a null value of 1. In a scenario like this, right? In a scenario like this range does not contain the null value of 1. That means that this is a significant result. So you have to tell both of those as well. So you have to interpret this value, you have to interpret this 95%, and then you have to interpret the fact that this does not contain the null value. So all of these 3 facts you have to interpret, right? If you know that much, that's enough, right? You won't be asked anything beyond that. So for relative risk and odds ratio, know the interpretation as well, right? Right. So that is all you need to know regarding that. So is there anything else you need to ask regarding, the study designs and the measures of association, statistical testing. So in the next class, we will try to cover about the significance testing and hypothesis testing as well, right? Right, station 4, this is a mix of pediatrics and community medicine. Right, so you are the MOH in a child welfare clinic at the MOH. So an 11-month-old male was brought in by his mother with the following growth curve, right? So the first question, right? What can you tell about the frequency of weighing measurements in this child? Tiloka, any idea? Just give you, even if you guess, that's fine, right? What can you tell about the frequency? Is it adequate or inadequate or what? What do you think? Nipuni, what do you think?
Yeah, I think it's okay until the second month, but afterwards, I think they haven't weighed the child frequently enough.
Exactly. So what is the frequency of weighing in an infant?
So you have to measure once a month.
Exactly. Monthly, right?
For, I can't remember for how long.
Yeah.
5
For 2
years, was it?
years.
Oh, 2 years.
No, 2 years. For up to 2 years, you need to weigh monthly. Then after 2 years, you need to measure every 3 months.
3 months.
Right? So basically, this up to 2 months, this was correct. She has brought the child monthly. Then after 2 months, there is a gap. So you can see this is marked every month. And then for the 3rd month, there has been no weighing. The 4th month she has marked, and again 5th month she hasn't weighed. 6th month she has, and then there's a long gap here. Right. So next, what is your interpretation of this child's growth curve? So this is the weight for age chart, right? So using the weight for age chart, what is your interpretation of this growth curve? Nipuni, what do you think?
Yeah, I think there is some sort of
So
growth.
just to clarify, this might not be clear, but this is above the line separating the green and the orange, right? So it's not
Okay.
touching that line, it's above. So then what is your interpretation?
So there is growth faltering.
Exactly. Why do you say this is growth faltering?
Because it has to, according, like if it followed the natural order, it should go up, and it's below, I think, 2 centiles. If it goes down, something like that.
What is the definition of growth faltering? How do you define growth faltering? Can you remember?
It's basically
Right. So right, it's okay. That's fine. That's fine. So growth faltering from a community medicine perspective, I'm saying you might have a slightly different, definition from pediatrics. From our point of view, growth faltering is between 2 consecutive readings, right? 2 subsequent readings. If there is inadequate weight gain, no weight gain, or loss of weight. All these 3 scenarios is growth faltering between 2 consecutive readings. In the clinical setup in wards, they might they might look over 3 or 4 readings, but in the community at MOH level, we act a little bit faster than that. We pick this up quite fast. We need to act quickly. So that is why we have it between 2 consecutive readings. So there, if you don't get, even if there is some growth, if there's some weight gain, but if it's inadequate, we consider that growth faltering. So how do you know if it's adequate or not? So ideally, the growth curve should follow this median line. So this is called the median line. Right here, this is called the median line. So if your growth is adequate, for there to be no growth faltering, it has to be parallel to this median line, right? So if there is some weight gain, but it is not parallel and it's going down, again, we call that growth faltering. No weight gain is growth flattening, right? This is called growth flattening, something like this, right? That is growth flattening, and loss of weight is something, it goes down, right? So either of those 3 are fine. So you need to interpret those as well. So here, of course, you are in the green zone, that's fine. But when you're interpreting in a general sort of manner, you need to interpret two things. You need to interpret the zone in which the last measurement was, and you need to interpret the trend. So growth faltering is the trend interpretation, right? In addition to that, if this was in the orange zone or in the red zone, you need to interpret that as well, right? Right. Moving onwards. So what are the equipment used to measure the growth parameters in children under 5? So growth parameters means what? Both? What are you measuring in children? Height and weight. So what are the equipment that you use, and what are the ages at which you use them? Any idea? You don't need to know the procedures for weighing and stuff and like that, but you need to know at least the equipment, proper equipment with the proper ages. Right, we will look into that. So then what is your plan of management for this child? Any
First
idea,
of
Lulu?
all, it's important to take a detailed history and
Exactly.
see if there is any prematurity or like any recent signs of infection and all of those. And then, so you have to eliminate any like organic causes that it could have happened
Yeah.
from. And
Okay,
then
next.
you have to see if the breastfeeding technique is adequate, and you have to assess all of that.
More than breastfeeding?
And supplementary feeding, and if there's any neglect and all of that.
What's the proper term? Not supplementary feeding. What's the correct term for that? It's called complementary feeding. Right? So at 11 months, exactly, complementary.
Yeah.
So at 11 months, before going into breastfeeding, focus more on complementary feeding, right? So by up to 6 months, your answer is correct. In a patient who is less than 6 months, who is coming with growth faltering and stuff like that, you have to look at breastfeeding. In a child who is more than 6 months, focus on the complementary feeding, right? Because breastfeeding that has expired, now you focus on complementary feeding. So how do you assess complementary feeding? This is the important part. So how do you assess that?
24-hour dietary recall.
Right, one, good. 24-hour dietary recall. And so you need to ask about dietary practices as well. So 24-hour dietary recall will tell you the types of foods and the food portions. The dietary practices will tell you how how they prepare the food, how often they give, how much they are eating. Is the child taking any unnecessary sort of stuff as well? Things like that. The dietary practices also you need to assess, right? So that's the complementary feeding part. Okay, so this can come up as a history taking station as well, from pediatric side as well as from community medicine side. So you need to know how to take a basic history of these patients who are coming with growth faltering and stuff like that as well. So in here you need to take you need to know how to take a comprehensive pediatric sort of type of history, and there you need to focus on complementary feeding, and you need to take a at least a brief 24-hour dietary history. Just ask, අද උදේට මොනවද කෑවේ, දවල්ට මොනවද කෑවේ, ඒ දෙක අතර මොනවා හරි කෑවද, and two things, important things, you need to ask about the type of food given and the portion of food given, and you need to ask about food intake, not just what the child was given, right? In pediatrics, in history taking, you have to ask about the intake of food, like පිගාට හෙන්ට ගොඩ බෙදාගෙන නැති, but the child will not have eaten all of that. So you need to ask about this in a pediatric history. How much did the child eat from the plate, right? That is an important thing. Right. So then, like you said, you need to rule out those organic other diseases like febrile illnesses and stuff like that. They might affect intake. Right. So then, assuming your history has been taken and there is some sort of complementary feeding issues, then you have then what do? You do advise them on fixing the complementary feeding, and then how do you follow up this patient?
You advise them to like obviously increase their calories and initially like any feeding difficulties and all of that to sort it out.
Yeah.
And afterwards, I guess you have to like regularly weigh the child and monitor the child to see if the progression
Exactly.
happens as normal. And if it doesn't, if it goes below to the yellow line, I think you have to go for a pediatric referral.
Exactly. So here you have to get that child back in 1 month. So you have to go ahead with 1 month, 1 monthly follow up. And if you can follow up for up to 3 months with growth faltering at the primary level, which is at the MOH level or the OPD level with growth faltering, unless there is crossing of these zones. So if the child crosses into the orange zone or the red zone, then it's an immediate referral. Otherwise, you can go up to 3 months. You can manage at your primary level, right? Right. The next, just a small thing regarding complementary feeding. One important thing during your counseling you can tell is try to make your foods energy dense. That's the word you have to use, right? Energy dense, where you have to add, oils, butter, margarine, and stuff like that to the food, and try to make the little food that child eats high in calories, right? Try to make the foods energy dense, right? And then you have to not just give, fix the feeding as well. You have to fix the feeding practices as well. Like, this is basic things, like don't give the child anything for 2 hours before main meal. Do not give additional, unnecessary snacks like biscuits, empty calorie stuff. Do not give stuff like that. Do not give a lot of chocolates and sweet stuff like that. Those you need to advise regarding these dietary practices as well. You need to assess it and advise regarding it, right? Right. Regarding regular attender, so you need to ensure regular attender. So weighing up to 2 years, it's monthly weighing. From 2 to 5 years, it's 3 monthly. And if there's any issue, you need to go back to monthly weighing even after 2 years. Height you measure at specific intervals: birth, 4 months, 9 months, 12 months, and 18 months. And afterwards, once every 6 months. If there's an issue, again, at higher frequencies, right? Length every 2 months up to 2 years, and height every 3 months up to 2 to 5 years, right? Right. So you need to take measurements accurately. For that, you need the proper reliable equipment. So you have the beam balance and the spring balance used to measure the weight. Right. These are the two scales, the two instruments. Right. Just know this. Right. The beam balance we used in infants, which is less than 1 year of age, and in more than 1 year of age, you use the spring balance. So this is the spring balance. This is the beam balance. Right. This is for infants. This is for more than 1 year old children. Spring balance. And then for length or height, both, you use the infantometer and stadiometer. Right? Infantometer, like it mentions, it's when the child is very small and they can't stand, you use the infantometer. That is usually up to 2 years of age. Although it's called infantometer, we usually use this up to 2 years of age, right? For children more than 2 years, we use something called the stadiometer. This is the same thing that we use for adults, right? And you need to know the proper procedure, right? So this as well. So there's a 5-point thing where the 5 points of the body must be touching the vertical axis: the heads, the scapula, the buttocks, the calf, and the heel, right? Right. So the interpretation, like I mentioned, you need to interpret the zone as well as the trend. And normal growth will be parallel to the median line, while growth faltering will be either inadequate weight gain, no weight gain, or loss of weight between two serial measurements or two consecutive measurements. Right? Right. So any questions up to now? Right. So right. So I'm so sorry. I'm going to have to end this session early today. So I do have some other stations as well. I'm sorry. I have some unavoidable circumstances, an unavoidable meeting I had to attend. So the rest of the stations I will discuss in the next session, which I think is planned on the 22nd at 9 p.m. So in addition to that, if there is anything extra that you guys want to discuss, you can send a message to the WhatsApp group, and we will discuss those specific topics. And in addition to that, if we get the new guidelines, if we manage to get all of the new guidelines, I will make sure to incorporate that and get the design the stations in a way to reflect the those guidelines, right? So I'm so sorry I had to end early today. So I will pick all these things up at the next session. So we will do an extended sort of session on 22nd. So if there are no other questions, we'll wind up for today. Good night, guys.
Thank you very much, sir.
Thank you, sir. Good night.
Okay, thank you.